Hello students, welcome to NExT. This is Dr. Santosh Patil, and with us today we have Dr. Ankit, the pharmacology faculty for MEDED. And today we are connecting to discuss the headache, right? Headache is one of the important topics. Now you take up any of the previous NEET PG question papers, at least one question related to headache appears. And that template is going to continue for the upcoming examinations, particularly when it comes to the context of national exit test, because this is one template from where the problem solving as well as comprehensive type of integrated questions can be created. So it is an easy topic for the examiners to frame question on it, and thus it is going to be important topic for us. Okay, so what will we do today is we will understand how we classify the headaches into primary and secondary headaches, and then we will focus on the primary headaches. And when we discuss the primary headaches, we encounter the types like migraine, cluster headache, and the tension type of headache. I will give you ideas how to identify the type of headache from the clinical questions. And after that, Dr. Ankit will talk about the management, primarily focusing on migraine. Okay, so let us begin by looking at the classification of headache. The headache currently is classified based on the International Classification of Headache Disorders version 3.0. ICHD 3.0. That is the current classification. And according to this, we classify the headache into two broad categories: primary headache and secondary headache. We have primary headache and secondary headache. So obviously, when I say secondary headache, that means there is an underlying cause which explains why patient is having headache. The MCQ that can be asked from the secondary headache is what is the most common cause for secondary headache. And when I say what is the most common cause for secondary headache, most of the students would answer saying, sir, brain tumor, brain hemorrhage, intracranial space of occupying lesion. But remember, I always ask the students a question. Did you recently go through an episode of fever? All of them would say, yes, sir. All of us have experienced an episode of fever, and headache was part and parcel of those episode of fever, right? So acute febrile illness is the most common cause for the secondary headache. Acute febrile illness is the most common cause for secondary headache. Apart from that, yes, we have intracranial space occupying lesions, CNS infections, including your meningitis as well as encephalitis, right? Then brain abscess. These are all, and the intracranial bleeds. Now, with respect to intracranial bleeds, there is one standard question asked from the previous exams, that is, where do you see thunderclap headache? Or in which condition patient describe an acute headache episode as the worst headache of my lifetime, right? And we all know what is the answer, right? That is subarachnoid hemorrhage. Thunderclap headache is seen in subarachnoid hemorrhage, and sometimes the examiners word it as the worst headache of my lifetime. Worst headache of lifetime, right? This is seen in subarachnoid hemorrhage. That's all from the secondary headache. Not so important for us to waste our extra time. Primarily, we should focus on the primary headache. Now, the primary headache is categorized into various categories. The first category is tension type headache. Tension type headache. The second category is migraine. Migraine. And the third category is what is called as trigeminal autonomic cephalgias or TACs. Trigeminal autonomic cephalgias or TACs. Now, under this heading, we have the major headache, that is cluster headache. Cluster headache. Second one is paroxysmal hemicrania. Paroxysmal hemicrania. And the third one is Sankt bar Suna. Sankt or Suna. What are these entities? We will discuss later once we go to the trigeminal autonomic cephalgias. But point number one, we are talking about the primary headache disorders, where you don't have an explanation in terms of a secondary cause for the pathogenesis of headache. Clear? Okay, now the very first question I would ask is, do we need an imaging to make the diagnosis of a primary headache disorder? Like if you have a patient where you're suspecting tension type of headache or migraine or TACs, do we need to do brain imaging? Should we do a CT scan or MRI? The answer is no. But we have to always make sure that there are no red flag signs for patients. So for the diagnosis of primary headache disorders, there is no need for imaging. The diagnosis is purely clinical, and that is what we're going to learn today, how clinically we make a diagnosis of primary headache disorder. But please remember one point, the imaging is recommended if patients have red flag signs. So that is the important point. In any question, if there is a red flag sign, then you don't make the diagnosis of primary headache disorder immediately. You have to rule out other causes or secondary causes. So what are those red flag signs? Okay, number one, patient having focal deficits. So patient has come to you with headache, but also has a monoplegia, hemiplegia, paraplegia, quadriplegia, or loss of vision, or some focal deficits. That indicates that there is something major underlying neurological problem and it is not a primary headache disorder. So in that case, we need to go for imaging. Number 2, if patient has signs of raised intracranial tension. Signs of raised intracranial tension. What are those? Bradycardia, right? Then gait disturbance, bowel and bladder dysfunction. So when these symptoms are there, projectile vomiting is also one. So when these symptoms are there, it is again a red flag sign. Patient may be having some intracranial bleed or intracranial space occupying lesion, right? Then third, age at the onset of headache more than 60 years. Age at onset of headache more than 60 years. Now, why is this point important? If the headaches are starting after 60 years, we're not thinking of primary headache disorders, but we are considering that as a red flag sign. Why? Which headache is very common, or which headache comes to your mind when I say age is more than 60 years? Right? Giant cell arteritis is a possibility. We should always rule that out in elderly presenting with the first episode of headache after 60 years of age. So that is what we need to remember. So these are the major red flag signs one should be aware of. And if there are red flag signs, we should go for imaging. Otherwise, we don't need the imaging. Okay. Now, coming to the diagnosis of headache and how we make or how we identify which type of headache it is from the given question. The real world scenario is important, but at the same time, identifying the headache type from the question is important, because they might ask you about the management, but until and unless you identify which type of headache it is, you will not be able to answer it, right? Okay, so the approach is, anytime you're dealing with a question or a case of headache, first question to ask ourselves is the lateralization of headache, whether the headache is lateralized or diffuse. Whether it is lateralized or diffuse. Now, what do I mean by lateralized? Whether it is unilateral, or when I say diffuse, bilateral, right? Now, if the headache disorder is characterized by non-lateralized headache, then there is only one primary headache, which is non-lateralized or diffuse one. Which one is that? Tension type of headache, right? So if the patient is describing that the headache is characterized by episodes where the episodes are affecting both sides of the hemicrania, then it is likely to be tension type of headache. Okay, the remaining primary headache disorders that we have discussed are all lateralized. Migraine is unilateral, the cluster headache is unilateral, the paroxysmal hemicrania is unilateral, and 𝐶NCT and 𝐶UNA are unilateral. All of those are going to be unilateral or lateralized headaches. Clear? So if the question says patient has got bilateral headache and there are no red flag signs and you're thinking of primary headache, it has to be tension type of headache, right? As simple as that. Now comes the next question. How do we distinguish between the migraine and other primary headache disorders? Because all of them are going to be lateralized. So the second important point to focus on is the duration of headache episodes if not treated. See, if someone gets an episode of headache and if he takes some NSAIDs or an appropriate medication, the headache might disappear in minutes to hours. But untreated headache episodes, how long do they last, right? So point to remember here is the migraine episodes last anywhere between 4 to 72 hours. Each episode of migraine lasts for 4 to 72 hours. If it is lasting for less than 4 hours without treatment, then it is unlikely to be migraine. An episode which comes for 30 minutes or 40 minutes is unlikely to be migraine. Clear? So first point is lateralization. If it is bilateral, it is tension type of headache. If it is unilateral, it is the migraine or other primary headaches, including attacks. Now, if the episodes are lasting for 4 to 72 hours, it is likely to be migraine. If they are lasting for less than 4 hours, they are most likely the trigeminal autonomic cephalgias. When they are less than 4 hours, they are most likely trigeminal autonomic cephalgias. Okay. Now, what all we covered under the trigeminal autonomic cephalgias? We spoke about cluster headache, paroxysmal hemicrania, and 𝐶NCT or 𝐶UNA, right? Now, how do we distinguish between these three entities? Okay, so all these three entities have something common in them. When you look at the name or the broad title given to these conditions, what do we notice? Trigeminal autonomic cephalgias. Cephalgia का मतलब क्या है? सर दर्द है, right? Cephal, head, algia, pain. Cephalgia means headache. Why are we calling it as trigeminal? Because the headache is primarily distributed in the distribution of the trigeminal nerve. It is more facial than the cranial. More facial than cranial. That's why we're calling it as trigeminal. That doesn't mean that it is trigeminal neuropathy. Headache is more facial than cranial. Then, why are we using the word autonomic cephalgias here? Because all these headaches share autonomic features along with the headache episode. So every time patient gets a headache, he will have some autonomic symptoms. What are the autonomic symptoms? Number one, nasal stuffiness. So headache episodes may be accompanied by nasal stuffiness. Number two, redness of the eyes. Number three, increased tear production from the eyes. And number four, facial flushing. And all these features are going to be unilateral, lateralized to the side of the headache. So if I have right-sided headache, I will have right-sided nasal stuffiness, right-sided red eye, right-sided increased tear production, and right-sided facial flushing. These are all autonomic symptoms, right? So these are the binding features between cluster headache, then the paroxysmal hemicrania, and SUNC or SUNA. Then how do we distinguish between these three? Because the headache character is very same, right? Facial more than cranial, having autonomic features. Then how do we distinguish? Again, duration comes into picture. So when I said we are talking about the trigeminal autonomic cephalgias, all of them last for less than 4 hours. But within that, looking at the duration, we can categorize them into cluster headache, paroxysmal hemicrania, and your SUNC or SUNA. Okay. So cluster headache episodes usually last between 30 minutes to 180 minutes. 30 minutes to 180 minutes. Every time it comes, it will last for at least 30 minutes. If you don't treat, it can last maximum of 180 minutes. After that, it will resolve on its own. The paroxysmal hemicrania usually lasts for around 15 to 30 minutes. 15 to 30 minutes. And the SUNC and SUNA, those episodes usually last for 4 seconds to 240 seconds, or you can simply remember 4 seconds to 4 minutes, right? 240 seconds ka matlab hai 4 minutes, 4 seconds to 4 minutes. The description is very same, unilateral headache with autonomic features, but episodes lasting for 30 to 180 minutes, you will call it as cluster headache. Episodes lasting for 15 to 30 minutes, you will call it as the paroxysmal hemicrania, and episodes lasting in terms of seconds, right, resembling almost like trigeminal neuralgia, then we will call it as SUNC or SUNA. Now, examiners are also courteous enough to give us extra clues for the diagnosis. What are the clues to look for? If it is cluster headache, examiner will have a tendency to mention two things. Number one, he will mention is about alcohol as a precipitating factor. And this question has been asked repeatedly. Alcohol is a precipitating factor for which of the following type of headaches? Cluster headache. Number two, he will mention seasonal clustering. See, the name cluster headache comes into picture because these cluster headache episodes ना वो एक साथ में एक cluster की तरह आ जाते हैं. मतलब like एक particular season में या particular month में there will be a run of headache episodes that patient will suffer, and after that there will be months or weeks of headache free period. Then again a run of cluster of headaches appear. That is why it is called as cluster headache. So that is a second clue that he will give. Now, if he wants to give you a clue about paroxysmal hemicrania, generally he will mention indomethacin responsiveness. Again, ये भी एक important MCQ है. Which of the following is an indomethacin responsive headache? So patients who have paroxysmal hemicrania, if you give them regular indomethacin, then their headache episodes will significantly come down. In fact, there are only two headaches where you see beautiful indomethacin responsiveness. एक है paroxysmal hemicrania and दूसरा है hemicrania continua. Hemicrania continua. Easy to remember है, दोनों में hemicrania word आता है, right? Paroxysmal hemicrania, hemicrania continua. Both of them respond to indomethacin. Okay. Now, if it is SUNC or SUNA, वो क्या extra clues देंगे हमारे हमको? पहला clue होगा SUNC or SUNA is very common in patients who have got pituitary adenoma. So he might mention that patient has been diagnosed with prolactinoma or a growth hormone secreting tumor, and now she has presented with unilateral headache episodes lasting for few seconds. That is a potential clue. The second clue that they will give you is there is a cutaneous trigger. So if you touch the distribution of the trigeminal nerve on the face, that location, it can trigger the headache episodes lasting for seconds. Okay. अभी एक question आता है. This is exactly resembling like the trigeminal neuralgia. तो क्या फर्क है? What is the difference between trigeminal neuralgia and SUNC or SUNA? The difference is in trigeminal neuralgia, you will be able to, like when you keep giving repeated stimulation, right? After some time, the repeated stimulation will not be able to trigger an headache episode. right? So there is a fatigability of the symptom. You cannot trigger the headache episodes after repeated stimulation, but in case of 𝐻 or 𝐶, you will not experience that, right? Every cutaneous stimulus will trigger an headache episode. But in case of the trigeminal neuralgia, after 5 or 6 cutaneous stimulation, you will have a dead period where the 7th or 8th stimulus may not trigger a headache episode, right? That is the way to mainly differentiate. Okay, so now we have understood how we diagnose a case of primary headache, right? So let me again summarize from the beginning. Any patient coming to you with headache, right? Especially we will think of these headache disorders only when there is a long history, right? You don't make a diagnosis of any of the primary headache disorders with a single episode of headache. Patient should have history of the episodes of headache before you make the diagnosis of primary headache disorder. And in those cases, the first point is to rule out the secondary causes, looking at the red flag signs, which we have understood. After that, we come to the diagnosis of primary headache. The very first question to ask is whether it is unilateral or bilateral. If it is bilateral, it is most likely to be tension type of headache. Examiners are also again courteous and they give some extra clues for the diagnosis of tension type of headache. The clues will be in the form of band-like sensation around the head. That is the usual word that we see in the questions, or sometimes they will mention vice-like grip. Those are two clues to go with the diagnosis of tension type of headache. Band-like sensation around the forehead or vice-like grip. और एक feature होगा, that is like most of the MCQs that you see about tension type of headache, the gender of the patient would be female because it is more common in females, typically middle-aged working class female. That is again an important clue. जितने भी हमने हेडेक डिस्क्राइब किया है ना, उनमें से सिर्फ एक हेडेक है जहाँ पे द क्वेश्चन का जेंडर होगा मेल पेशेंट. राइट, कैन एनीबडी टेल मी व्हिच हेडेक टाइप आई एम टॉकिंग अबाउट? राइट, सी इतने सारे डिस्कशन में अल्कोहल एक बार फिगर हुआ, राइट, एंड अल्कोहल तो मेल्स ही ऑब्वियसली ज्यादा पीते हैं. सो क्लस्टर हेडेक इज मोर कॉमन इन मेल्स. So rest of the primary headaches, be it migraine, be it tension type of headache, or the other primary headaches that we have discussed, they are more common in females. So cluster headache is the one where you might see male as a gender. Okay, now if it is not diffuse or bilateral and it is unilateral, then you have migraine as a possibility. Then you have the cluster headache, paroxysmal hemicrania, and 𝐻 or 𝐶 as a possibility. Right? Duration of headache episode becomes an important point for differentiation. But apart from that, there will be some potential clues for migraine. अगर ये migraine है, तो usually examiners will mention about photophobia, phonophobia as the clue. Then if it is classical migraine, the examiner will also mention about the presence of aura. Right? So migraine episodes are almost always accompanied by photophobia or phonophobia. अगर आप migraine experience कर चुके हैं, तो you know that you would prefer to lock yourself in a room. You don't want to get exposed to flashing lights, you don't want to get exposed to the noisy environments. It's common, right? Photophobia, phonophobia. And if it is a classical migraine, you will have aura. And aura के बारे में हमको 2-3 points याद रखना है. Aura duration. The aura duration should be between 5 to 60 minutes. 5 to 60 minutes. This is extremely important because anything that lasts for less than 5 minutes is unlikely to be aura and it may be a red flag sign. And anything that is lasting for more than 60 minutes is also unlikely to be aura or it may be a red flag sign. ये क्यों इंपॉर्टेंट है मैं बताता हूँ. एक टाइप ऑफ माइग्रेन है, ज्यादा डिटेल में जाने की जरूरत नहीं है, बट देयर इज अ टाइप ऑफ माइग्रेन कॉल्ड एज retinal migraine. In retinal migraine, patients develop unilateral blindness as a aura feature. Unilateral blindness as a aura feature. But remember, aura is a reversible symptom. So the blindness is also going to be reversible. वो पूरा revert हो जाएगा. But if it is lasting for less than 5 minutes, then we have a other possibility. Right? What is the possibility? There is something called as amaurosis fugax. So when transiently a clot appears in the retinal artery and causes a retinal artery occlusion, you can develop the blindness. We call it as amaurosis fugax. Now, if it is amaurosis fugax, even if the symptoms have like disappeared within 5 minutes, the chances are that the patient will develop permanent blindness when he gets next load of the clots in the retinal artery. So that is why it's an important red flag sign. And at the same time, if it is lasting for more than 60 minutes, probably it must be a major organic disease and it can't be aura. Or an example दे सकता हूँ, there is something called as hemiplegic migraine, where during that, when migraine starts, right, just before that headache appears, during the aura phase, patient can develop hemiplegia. Okay. Agar hemiplegia lasted for less than 5 minutes, it is most likely TIA. It is most likely transient ischemic attack. And if the hemiplegia lasted for more than 60 minutes, then वो तो hemiplegia है, वो aura नहीं है, right? If it is aura, then it should have reverted back to normalcy within 60 minutes. So any question में और clinical cases में याद रखना है, if patient has got aura, it should last for 5 to 60 minutes. More than that and less than this is unusual, right? It should prompt you to think of secondary causes for those symptoms as well as headache. Okay, so now I hope you got a fair bit idea about how to come to the diagnosis of any case of headache from the clinical STEM kind of questions. Okay, now once it comes to the management, there are only few important areas to focus on. Number one is migraine management. Most of the questions about management of headache come from the migraine management, and they're starting from the mechanism of action of drugs to the primary treatment and the preventive treatment. All of that is going to be important. So for that, I will pass the baton to Ankit sir. Ankit sir will take you through the management of migraine. After that, I will add a few points about the management of the tension type of headache and cluster headache. Over to you, sir.
Thank you, sir. Such a wonderful flow charts. I believe now it is easy for students to understand. So now we will come to the pharma part. Sir, why migraine occurs? As the sir has already explained, sir ने आपको पहले ही explain कर दिया है कि migraine जो है वो primary headache है. Primary headache means हमें कोई भी identifiable cause नहीं मिलता. हम CT scan, if we will do CT scan or MRI, hence even in imaging, we will not find any organic cause or any space occupying lesion, any bleed. So first question occurs that why migraine occurs? And the correct answer is, sir, we don't know why migraine occurs. But because we don't know, that doesn't mean that we cannot think about it. So we have hypothesis. So we have hypothesis that how migraine occurs. And the most accepted hypothesis for migraine is serotonergic hypothesis. Okay. So serotonergic hypothesis for migraine right now is the most accepted one. But right now we don't know why migraine occurs. So let me explain you. So it's a little bit tricky. If you will understand this, you will be able to understand how the drugs are acting basically. So let's say this is a neuron. Let's say it's a neuron around trigeminal nucleus. So what happens? This neuron, it releases serotonin plus other inflammatory mediators. Okay. Now, as it causes release of serotonin and other anti-inflammatory mediators, remember, this serotonin causes vasoconstriction of this end arteries. These small blood vessels which are going to a neuron, it leads to vasoconstriction. Similarly, so I'll draw a beautiful diagram for you to make you understand better. Suppose this is an artery which is coming, and this is a vein which is going back from a neuron. Now what happens? There is vasoconstriction of this artery and vein because of serotonin. Now what will happen? Because of this reason, the blood which is coming through this artery will be diverted towards a vein. Agreed? So can any student tell me, sir, if this end arteries and veins are constricted, what will happen to AV shunts? Any student who can tell me? If the blood is getting diverted back, देखो बेटा blood आ रहा था, पर आर्टरी और वेन जो नर्व को सप्लाई कर रही थी वो तो कंस्ट्रिक्ट हो गई, तो सारा का सारा ब्लड बेटा क्या हो जाएगा? वो डाइवर्ट हो जाएगा वापस की तरफ, है ना? सो एनीवन हु कैन टेल मी व्हाट हैपेंस टू दिस एवी शंट्स? कोई बच्चा बता सकता है एवी शंट में क्या होगा? यस, एवी शंट्स विल बिकम डायलेटेड. That is why we commonly say that in migraine, generally we have pulsatile, throbbing headache. So it is a vasodilatory in nature because these vessels become dilated. And remember, around these nerves, AV shunts, we have sensory nerves. These sensory nerves become stimulated, which gives us a feeling of a headache. Now the point is, which drug we give for the treatment of migraine? Remember, in migraine, we give a drug known as वेसोकंस्ट्रिक्टर्स। सो बच्चे इस बात को समझना बहुत जरूरी है, माइग्रेन में पहले से ही वेसोकंस्ट्रिक्शन हो रही है, एंड फॉर द ट्रीटमेंट ऑफ माइग्रेन वी आर अगेन गिविंग वेसोकंस्ट्रिक्टर्स। क्या ये बात समझ आई? तो बताइए, कैन वी से दैट दिस वेसोकंस्ट्रिक्टर्स दे विल कंस्ट्रिक्ट this dilated arteriovenous shuts? Agree? And the class of drug we are having in vasoconstrictors are 5-HT 1B 1D agonist. कौन से ड्रग है बेटा हमारे पास? 5-HT 1B 1D agonist, and the drug of choice during an acute attack of migraine, the drug that will stimulate this receptor, we call it as ट्रिप्टान्स। क्या बोलते हैं इन ड्रग को? ट्रिप्टान। आप सबने नाम सुना है, सुमाट्रिप्टान। इससे पहले एक ड्रग्स थे जो आज भी हम कई बार यूज करते हैं, लाइक इरगोटामीन, सो व्हाट आर द ड्रग्स वी हैव फॉर माइग्रेन? 5-HT 1B 1D agonist. Now let me tell you how do these drugs they are helpful in migraine. ये माइग्रेन में हेल्पफुल कैसे हैं? So I will just tell you how they will act. First point, this 5-HT 1B 1D receptor, it is present in neurons. 5-HT 1B 1D receptor, it is present in neuron, and this 5-HT 1B 1D receptor, it is also present in AV shunts. It is also present in AV shunts. Now, when you stimulate this 5-HT 1B 1D receptor, remember 5-HT 1B 1D receptor, if you will stimulate on nerve, remember it will inhibit the release of serotonin, and it will also inhibit the release of one inflammatory mediator which I will be telling you, CGRP. CGRP क्या है बेटा? थोड़ी देर में पढ़ेंगे. So first action is 5-HT 1B 1D agonist, they inhibit the release. Second point is 5-HT 1B 1D agonist, they produce vasoconstriction of this dilated AV shunts. Okay, so this is their main mechanism of action. So let's discuss what are the drugs we have for treatment of migraine. So remember, the drug is 5-HT 1B 1D agonist. The first class of drug is triptans. The first class of drug we are having is triptans. And these drugs are 5-HT 1B 1D agonist. The second class of drug we have is ergotamine, and these drugs are given in acute migraine. They are given in acute migraine. Now we have a bit of new drug that acts on a similar receptor, 5-HT1F agonist. This drug, a new drug, is lasmiditan. This lasmiditan has also been recently got approved for treatment of acute migraine. But remember, triptans किस पे काम करते हैं? 1B 1D. lasmiditan किस पे काम करता है? 1F. So let's see the mechanism of action of these drugs in migraine. Can we say they are vasoconstrictors? They close AV shunt, first point, and they reduce the release of serotonin and CGRP2 from neuron. तो ये बात अब हमें नहीं बोलनी. Now let's talk about individual drugs. So if you talk about triptans, a very famous drug which we all students, all faculty know, the most commonly prescribed drug is sumatriptan. हम सब जानते हैं sumatriptan के बारे में. Remember, sumatriptan is the most commonly used drug. Among triptan, it is the most cost effective. सबसे सस्ता भी यही drug होता है. So overall, the most commonly prescribed drug, the drug of choice is sumatriptan. Now, another good thing about sumatriptan is it has multiple routes by which we can give. Remember, we can give orally. If we can give a drug orally, sir, why there is a need of making another route? There is a reason behind it. Remember, in migraine, during aura, patient may have nausea and vomiting. Nausea and vomiting is one of the feature of aura. Now remember, Can you give a drug orally to your patient when a patient is having vomiting? That's a big problem. That is why we made nasal spray of sumatriptan. That is why in small children, rectal formulation can be given, intravenous formulation is there, and TD stands for we have transdermal patches also. Agreed? Now the question comes, any other drug apart from sumatriptan which can be given as a nasal spray? क्या हम nasal spray की तरह कोई और drug दे सकते हैं? This is an MCQ. The drug name is zolmitriptan. So when you will give zolmitriptan? When the patient is having vomiting. Now few one-liners. Remember, elytriptan. E for Eli, it has best efficacy. Best efficacy means most effective. Earlier it was rizatriptan which was most effective, but now the studies have shown that elytriptan, it is even better than rizatriptan. Rizatriptan पहले most effective था, अब कौन सा आ गया है? अब elytriptan हो गया है. And why rizatriptan was very effective? Because R for Riza, it was having rapid onset of action. The fastest onset of action we were having of rizatriptan. Then we have frovatriptan. Frova means far. जो सबसे far तक जाएगा, it is the longest acting drug. Agreed? Then we have elmotriptan, naratriptan. Naratriptan, when given orally, it has maximum oral bioavailability. Now, you have to remember sumatriptan, Eli, Riza, Frova, and Zolmi. One-liner, all liners, one-liners are MCQ for you. Remember this point. Now, what about ergots? Remember, ergots, they also act on 5-HT1B1D receptor. But remember, they are not specific drug for only this serotonin 5-HT1B1D receptor. Remember, ergots, they act on many other receptors also. Ergots, remember, they have alpha blocking action. They have alpha blocking action. Now there is a point out here. Remember, alpha blockers, they are vasodilators. Alpha blockers are vasodilator, while 5-HT1B1D agonists, they have vasoconstrictive action. Now, because of excessive vasoconstriction outside the brain, let's say in fingers, if there is vasoconstriction, these ergots can lead to a very dangerous side effect known as ergotism, which I will be explaining you. Because they don't just act on brain, they act on other organs also. That is why from ergotamine, this is a recently asked MCQ, we made dihydroergotamine. Can you tell me in ergotamine and dihydroergotamine, what is extra? Can we say hydrogen is extra? That means we have done hydrogenation of ergotamine. The question came that if there is hydrogenation, what difference it produces? Remember, hydrogenation increases alpha blocking action. It reduces 5-HT1B1D action, but increases vasodilatory action. So can you tell me dihydroergotamine has lesser risk of which side effect as compared to ergotamine? The answer is ergotism. So dihydroergotamine has lesser risk of ergotism. Now, beta, what is ergotism? See this picture. And remember one point, always, which always I tell in my to the student, you know a word ergot. So remember, word ergot, if you take ergot, the fingers will rot. So if you take ergot, the fingers will rot. We remember this statement. So this is ergotism. Now, why this ergotism happens? Because they produce vasoconstriction or dry gangrene of fingers. Because in fingers, we have end arteries. If you constrict them, there is no anastomosis, there is no alternative blood supply. So the fingers will become necrosed, ischemic necrosis. And when ischemic necrosis occurs, the fingers will become black. So this is known as ergotism. So ergotism is seen with the drugs which we give for migraine. Recent question, how do you treat ergotism? For the treatment of ergotism, remember we give a vasodilator that is nitroprusside. तो ergotism का treatment हम कैसे करते हैं? We will open this vessels, that is nitroprusside. So let's see the side effect of triptans and ergots. And we can remember a mnemonic HERD, heard. H for, just think it's very simple. If there is vasoconstriction, what will happen to the pressure? The blood pressure will rise. Hypertension. Similarly, if there is vasoconstriction in coronary artery, it will lead to vasospastic angina and MI. Similarly, there will be tingling and loss of sensation in fingers. This is known as erythromelalgia. There is Raynaud's phenomena, and the most severe one is ergotism, that is dry gangrene of fingers and hands and feet. Done. Now, let's talk about the management part. So let's classify our patient. When a patient came to your OPD or emergency with acute headache, so let's call it as an acute attack of migraine. So we know that in acute attack of migraine, there is pulsatile headache because of vasodilation. And in classical migraine, sir has told you that there is associated symptoms which you call it as aura, like vomiting, photophobia, phonophobia, like tinnitus, etc. Now, let's see how do we manage. To manage headache, if it is a mild headache that is just lasting for around 4 to 8 hours, we give simple painkillers like NSAIDs, non-steroidal anti-inflammatory drug, like paracetamol, aspirin, ibuprofen, and naproxen. So you can remember a mnemonic pain for it. Second point, you can also add caffeine. This is a question. Caffeine has shown to be beneficial to treat headaches and migraine. But remember, simple NSAIDs generally cannot treat migraine if it is moderate to severe variety. Moderate to severe means it is lasting for more than 8 hours continuously. Then NSAIDs are useless. Hence, the overall drug of choice for migraine is triptans. Okay, so triptans are better drug for headache treatment. Yes, you can give ergotamine, but remember, as we have just discussed, triptans and ergotamine, they have same side effect, HERD, heard. Hence, you should never combine them together. But I will tell you one thing, if you go to the market, you very commonly find their combination. Remember, those combinations are illegal or irrational. We should not combine triptans and ergots together because they have same side effect. There should be at least a gap of 24 hours between a triptan and ergot. So that's a very common thing which we doctor generally overlook. So as a doctor, आपने हमेशा याद रखना है triptans और ergots को काम नहीं करना. Now, just imagine patient is hypertensive, patient is having MI or angina. We cannot give triptans. If triptans are still not producing effect, then at the last resort, we have to give the best painkiller. And the best killer in triptan resistant cases is opioids. Which opioid we can give? Morphine and pethidine IV. And we have one opioid which we specifically made for migraine. That is butarphenol. And this butarphenol opioid, it is available as a nasal spray. It has been specifically approved for acute attack of migraine. Now, this is what we have taken care of headache. But what about aura? Aura ko bhi to theek karna hai. There is photophobia, phonophobia, there is nausea, vomiting. Nausea, vomiting is the most cumbersome. So if there is nausea and vomiting, don't you think we have to give anti-emetic drugs? So yes, in migraine, we have to stop vomiting also. And for the treatment of aura, we give anti-emetics. And these anti-emetics are dopamine blockers. They block dopamine receptors, and they have shown to be effective in migraine. So domperidone, metoclopramide, and antipsychotic drugs, they are also effective in migraine aura because antipsychotic drug also blocks dopamine receptor. So let's write two name of antipsychotic. First is prochlorperazine. Second is chlorpromazine. So antipsychotic drug भी migraine में दिए जाते हैं. Now the last point is migraine in pregnancy. Remember, the safest drug for migraine in pregnancy is NSAIDs. But if it is still not controlled, we can give which triptan? The only most tested triptan in pregnancy is sumatriptan. Done? So this is about acute treatment of migraine. Now the last part is, let's say there is a patient who is having migraine headache for more than 15 days a month. एक महीने में 15 दिन से ज्यादा हेडेक रहता है. Don't you think if you are having headache, you cannot do any functional work? So remember, if a patient is having headache for more than 15 days a month, we call it as chronic migraine. And in cases of chronic migraine, we have to give a drug for prevention or prophylaxis of migraine. Agreed? So what are the drugs we give for prophylaxis of migraine? The mnemonic is in front of you. We can write a mnemonic, Bactam. But you don't have to remember each and every drug. The first drug is beta blockers like propranolol. Propranolol is overall the drug of choice for prophylaxis of migraine. We can use other drugs like timolol and metoprolol, but propranolol, prophylaxis of migraine. If it is not controlled by propranolol, then we start anti-epileptic drugs like valproate, topiramate, and gabapentin. 3 drugs are approved. And remember, the first 2 classes of the drugs are most effective drug. Other drugs are also given. They are very cheap. In our country, low resource setting, we very commonly give other drugs. But if you talk about Harrison, American people who are rich people who don't have any problem of money, then we only talk about which is the most effective drug. But if you talk about India, very commonly you will find the drug flunarizine. Flunarizine is a calcium channel blocker. Another calcium channel blocker which we can give is verapamil. And this flunarizine, you will go in the market and you will see that it comes in combination with amitriptyline very commonly. So amitriptyline or nortriptyline, they are tricyclic antidepressants. Yes, they are very commonly used in India. So this amitriptyline, nortriptyline, heard about a tablet named Triptomer. That's a Triptomer is amitriptyline. So very commonly used drug. Yes, we can give anti-serotonin, which will block serotonin, like cyproheptadine and methysergide. I want to tell you one thing. M for methysergide. Methysergide was the first drug for migraine we developed. It was the first drug for migraine was methysergide, but this methysergide, as we can see, it is having ERG word. It's also an ergot. Now remember, this ergot is given for very long-term duration. Why long-term duration? Because we are giving for prophylaxis of migraine. And when we give methysergide for very long-term duration, it produces a side effect known as retroperitoneal fibrosis. So what is the side effect of methysergide? Retroperitoneal fibrosis. That is why this drug nowadays is no longer used, but it is an MCQ, which is asked from you student in exams. Lastly, we have MAO inhibitors like phenelzine. Now, there are certain other therapies which we can give. Although we rarely give them in migraine, you can give injection of botulinum toxin. It has pain relieving property. You can give one plant product known as pitacite. There is a drug known as clonidine, which is also sometimes used, but it carries a risk of hypotension. So rarely we use these drugs. We generally limit our choice of our drug from this mnemonic which I have told you. जो मैंने आपको mnemonic बताया है ना बेटा, है ना? वहीं तक हम लिमिट करते हैं. Now, the last part from my end in pharma is there is a new class of a drug which is getting a lot of attention in migraine. And these drugs are CGRP2 inhibitor. CGRP2 inhibitor. तो बेटा अभी हमने पढ़ा था कि न्यूरॉन दे रिलीज CGRP, which is an inflammatory mediator. So what is the full form of CGRP? We all will write calcitonin gene related peptide. Remember, it is not calcitonin hormone. No, it's a neurotransmitter which is released in our brain and it causes pain in migraine. It carries painful sensation. So we block CGRP2 inhibitor. Now, the first class of drug among CGRP2 inhibitor, which are given in acute migraine, oral and IV, are GPANTs. We call them as GPANT because they all end with the word GPANT. Okay? तो क्या नाम है? Ubrogepant, Rimegepant, Javagepant, any Gepant word is coming. Remember, they block CGRP2 receptor. Recently, we came with antibodies against CGRP2. We have developed monoclonal antibodies against CGRP2. As you can see, MAB word is coming. So these monoclonal antibodies are against CGRP2. But remember, they are mainly given for prophylaxis of migraine. Gepants are mainly given for acute migraine. Monoclonal antibodies are given for prophylaxis of migraine. Don't worry, mindful philosophy, we will explain. Valproate beta, I will tell you why valproate is effective. Just give me 1 second. Why valproate is effective in migraine, why beta blocker are effective, I'll tell you. You have raised a very good question. But first, erinumab, remember, it directly blocks CGRP2. It directly binds to CGRP2 receptor, CGRP molecule, which is circulating. But other drugs, eptinezumab, galcanezumab, and fremanezumab, they block not CGRP, they block CGRP2 receptor. They block the receptor of CGRP2. Erinumab directly blocks CGRP. Fine. So these are the drugs we have for migraine. Now, beta Mridul, mindful, you asked me a question. I will not write it because nobody will be going to ask you. But let me tell you the answer. Why valproate is used? Why propranolol is used? I'll tell you the reason. Remember, valproate, it blocks sodium channel. It's an anti-epileptic drug. Hence, it directly suppresses neurons in our brain. If neurons are not working, do you think the neurons will release serotonin? Neurons will release CGRP2? The answer is no. That is why we give anti-epileptic drug. They suppress neurons, which is releasing this molecule. Second point, why propranolol is used? Propranolol has two properties. The first property, propranolol is a beta blocker. It produces vasoconstriction. Second point, the main reason why we use propranolol is propranolol, just like lignocaine-like drug, propranolol has local anesthetic action. Just like lignocaine and valproate, propranolol also blocks sodium channels on neurons. Lignocaine also blocks sodium channel on neuron. Hence, propranolol can suppress neurons and inhibit the release of inflammatory mediator. This is known as some membrane stabilizing action of propranolol, which I used to tell you in beta blocker chapter. So this is all from my side, beta. I think I have answered your question. Mindful philosophy, a nice name. So back to you, sir.
Okay, so guys, sir has given you a very beautiful and succinct review of the pharmacological management of migraine. But from medicine, you can also anticipate questions about the non-pharmacotherapy of migraine. So there are certain interventions which can be helpful in treatment of migraine. And I want you to remember two important things here, right? Number one, for the non-pharmacological management, first thing is something called as STMS, which stands for single pulse transcranial magnetic stimulation. Single pulse transcranial magnetic stimulation, SPMS, single pulse transcranial magnetic stimulation. Okay, now this has been US FDA approved for two situations. One, it can be used for the acute management of migraine, and it can also be used for the prophylaxis of migraine. This is a non-pharmacotherapy. What patient need to do is, there will be a helmet-like device which can generate a single pulse of magnetic stimulation. So every time he wears and presses a button, it will generate the magnetic stimulation. Okay, and that magnetic stimulation can play with the vessel tone, and thus it can be useful for treatment of acute migraine. And if patient takes multiple stimulations in a given day, it can also be prophylactic. So it can be used for both acute as well as prophylactic. Then the second non-pharmacological treatment is the vagus nerve stimulation. Vagus nerve stimulation, that is the second non-pharmacological treatment, which is mainly approved for the prophylaxis of migraine, not for the acute treatment. Right? So those two things you should add to your pharmacological management of migraine. And there is also one more drug. I wouldn't call it as non-pharmacological, it is rather pharmacological, which can also be used for the prophylaxis of migraine. I'll give you a clue. You use that drug for reducing the wrinkles on the face of beautiful women. What drug is that? Right, your botulinum toxin. So the scalp injection of botulinum toxin can also be used for the prophylaxis of migraine. It has been catching up these days among the neurologists, because pharmacotherapy does bring in its own set of unwanted effects, right? So patient may not be able to tolerate the prophylaxis. For example, see, many of the patients of migraine that I treat are young individuals, and if they are males, then when we're giving them beta blockers, there is a concern about erectile dysfunction, right? So there are certain side effects that these prophylactic medications come into, like they bring into the picture, and this botulinum toxin can kind of override it when you're appropriately dosing it. The only limiting factor is the cost. Okay, so this is about the management of migraine. Now, a few points about the management of tension type of headache and cluster headache and the other two primary headaches. So tension type of headache, only two MCQs can be asked. What is the acute management? The answer is very simple. The acute management is an NSAID. Tension type of headache, give a simple NSAID. You don't need even a very potent NSAID like the naproxen. A simple NSAID would work for most of the patients. And for prophylaxis, what is the drug of choice? A repeatedly asked question. Fleetingly, Ankit sir has already discussed about the drug. He has also told the commonly available brand name of the drug. Right, we use tricyclic antidepressants in low doses. The dose lower than the antidepressant doses. And the most commonly used drug is amitriptyline. The usual amitriptyline dose that we prescribe for the prophylaxis of tension type of headache is around 10 milligrams per day. For your antidepressant, you start upwards of 25 milligrams per day. Here it is usually 10 milligrams per day. We generally give it for a very short duration, means like around 3 months. Now for migraine, you can give the prophylaxis for months together. I have patients who have been on prophylaxis for years together. But for the tension type of headache, we only give for 3 months. There's a reason for that. See, because if someone is having tension type of headache, there are probably lifestyle and stressor related factors which are contributing to it. So if patient can overcome those stress factors, then they no longer need the prophylactic medication, right? That is the thought behind it. Now coming to the cluster headache. Cluster headache, when we discussed it, we learned few things there, right? One, it is an episodic headache, comes out with episodes lasting for 30 minutes to 180 minutes, and there will be seasonal clustering, right? So when you have a patient of cluster headache, first thing you need to do is treat the present episode of headache, acute management, right? Then second, you need to break an ongoing cluster. So now he's experiencing headache today. He might have had a run of headaches for last few days, and he will continue to have a run of headaches for next several weeks before he hits a headache free period. So you need to break an ongoing cluster, and for that we call it as the short-term prevention. So we have to manage acute short-term prevention, and we have to also, in selected set of patients, prevent the next cluster from appearing. So we call it as long-term prevention. So for the acute management, the drug of choice is oxygen. The drug of choice is oxygen, inhaled at 10 to 12 liters per minute for 15 minutes. 10 to 12 liters per minute for 15 minutes. Okay, what alternatively we can use to oxygen? We can think of using sumatriptan. Studies have shown that it is more effective than the oxygen. but not in the oral form. Oral form, it is inferior to oxygen. In the injectable form, subcutaneous and IV, it is superior to oxygen. In one of the INICET, there was a question around it. So they had mentioned, the question was asking which of the following is the most effective treatment for the acute management of cluster headache. They had mentioned oxygen, they had mentioned sumatriptan in injectable form. Okay, so please remember, oxygen is a drug of choice because it at that short duration of oxygen exposure, it doesn't have any major side effects. That is why it remains a drug of choice. But the effectiveness wise, it is the sumatriptan in injectable forms. Clear? Now, for the short-term prevention, the drug of choice is dexamethasone or oral corticosteroids, either injectable or oral corticosteroids. Most commonly, we prefer oral corticosteroid. That is the drug of choice for the short-term prevention. The short-term prevention is basically you're trying to break an ongoing cluster. And for the long-term prevention, the drug of choice is verapamil. Verapamil is the drug of choice for long-term prevention. Okay, now moving on to the management of the paroxysmal hemicrania. When we were discussing paroxysmal hemicrania, I told examiners are very courteous and they give you clues, and the clue is indomethacin responsiveness. So when it comes to paroxysmal hemicrania, indomethacin is the prophylactic agent. Indomethacin is the prophylactic agent. There is no debate about the acute management because you can as well use indomethacin if there is a breakthrough headache episode. Like you give indomethacin with the hope that it will prevent. If an episode happens, you can give indomethacin itself. Okay. Now coming to SUNCT or SUNA. Now tell me, what is the drug of choice for the acute management of SUNCT and SUNA? Now every time I ask this question, right, students will say NSAID or some or the other answer, but just go back to the discussion, right? We were talking about the SUNCT and SUNA. How do we diagnose it? Unilateral headache, right, with autonomic features lasting for 4 seconds to 240 seconds. So by the time patient decide करेगा कि मुझे अभी headache हो रहा है और मुझे medicine लेना चाहिए, that episode is gone. अगला episode आने वाला है. So there is no role of acute management when it comes to SUNCT and SUNA. It is only about the prophylaxis. And the drug of choice for the prophylaxis of SUNCT and SUNA is lamotrigine. Lamotrigine is the drug of choice for the prophylaxis of SUNCT and SUNA. But please remember one extra point, those who are preparing for INICET, or if there is any postgraduate student who is watching this video module, Harrison mentions that in those patients where the SUNCT and SUNA episodes are relatively longer, in the sense they're lasting for 3-4 minutes, not seconds. Most cases, in 90% cases, it lasts for just 3-4 seconds, not more than that. But in those cases where it is lasting 3-4 minutes, there you can use lignocaine. Okay, IV lignocaine can be used to abort that episode. Okay, but it is a point which is only mentioned in Harrison. I didn't find it in most of the other standard textbooks discussing about it. Most of them clearly mention that there is no role of acute management because 90% of the patients will have the episodes lasting for seconds. Okay, so this is about the summary of how we manage almost all the primary headache disorders that we need to know for the NEET as well as the NEXT exam. So from the beginning, how we approach to make a clinical diagnosis to how we decide about the management. All of that has been covered today. And what I would recommend is, after the video lesson, please go to the PW Meded app, go through the Q bank on both pharmacology as well as medicine about the headache. That is where you will get to apply what you have learned today, right? Without doing that exercise, the whole purpose of watching this video is not served, right? So please head to the Q bank, solve the questions, apply what you have learned today, right? You might encounter clinical scenarios, you might encounter questions about the drug side effects, as well as you might encounter questions directly asking you what is the drug of choice, what is the contraindication. Hopefully all of that should be answerable from what we have discussed today. Sir, you have anything to add?
Nice, sir. Even I learned a lot today. I pushed up my knowledge of medicine. So it was such a nice session. I hope you student enjoyed it also. So keep learning. That's all from my side.
Okay, so guys, keep an eye on the Meded NEXT channel because we will be coming out with many such integrated sessions on a daily basis. Tomorrow also we will be having a session talking about the meningitis. It will be an integrated session between medicine and pediatrics. How the diagnosis and management of medicine, the meningitis is going to be different between pediatrics and medicine. That is the key take-home point from tomorrow's session. So don't miss it out. For now, we are signing off, guys. I'll see you all tomorrow. Till then, have a good time. Thank you.
Good night.
Thank you, sir. Bye. Good night.